Perfect. Recording. Thank you, everyone.
Hello, everybody. Welcome to the May Coalition of Blacks Against Breast Cancer educational session. As you might know, we are all sitting in the same room. So this was our first actual hybrid CBBC ever. We had our sharing group with folks that were sitting in the comfort of their home, and we're here at the Cancer Support Community for individuals who felt comfortable in joining in person. So please spread the word that we are back doing a combination of live, and we will remain virtual as well. We're here today to have our educational session, and we're going to be talking about a really important topic related to research and the importance of research in making sure that we're able to make strides against the increased mortality rate in Black breast cancer patients. Only through research can we make sure that we have new and effective treatments that enhance the quality of patients' lives as well as their longevity. So with me, I have Dr. Angela Allen, and I'll let her introduce herself in a second. I'm Dr. Michele Halyard, one of the Coalition of Blacks Against Breast Cancer Co-Founders and a radiation oncologist from Mayo Clinic. And I have with me Dr. Don Northfelt, who's one of our medical oncologists in breast, specializing in breast at Mayo Clinic. So we're going to turn it over to Dr. Allen, and she's going to set the stage.
Yes, thank you very much, Dr. Halyard. So again, my name is Dr. Angela Allen. I'm a Ph.D. prepared nurse, in which I do research not only in the clinical setting, particularly in Banner, but also I do research within the community setting. And so the stage, as Dr. Halyard pointed out, we'll talk about clinical trials. Another name that individuals may recognize is clinical studies. Now, this may be very familiar to many of you all because you've heard this in the last 2 years where we've talked about COVID clinical trials and clinical studies, which means this is where individuals, humans who have been involved in studies, particularly any research that involves humans. This research may entail drugs, treatments, medical equipment, and as you all may be very familiar with, vaccinations. So in clinical trials, this is a heavy topic, not only for as it relates to what we're going to talk about as relates to the disease, but also for the community in which we're talking to. It has always been a challenge, particularly with engagement and recruitment for individuals, particularly people of color, to be involved in clinical trials. And as I've mentioned, clinical trials holds a huge stance when it comes to, and I'm going to focus mainly on drugs. Clinical trials, typically what happens is an individual scientists will identify a certain drug that may have been tested and proven to work with non-humans. Animals, you may have heard of rats or mice being involved, monkeys or other types of animals being involved in certain types of clinical trials. And this doesn't happen overnight. It goes on for years to determine if these medications, treatments, or vaccinations are appropriate. From there, clinical trials is then tested on a group of individuals that may have the disease, and we consider those people who may be eligible. That is a particular group that they're focusing on, that is a particular drug. Again, the individuals may have to have some type of complications, or maybe those individuals that are recognized to need that medication, drug, or treatment. And in some cases, and I would have to say most cases, clinical trials are actually allowing individuals to be the sample size to determine if that medication is effective. Clinical trials have been identified, most have been identified to be free, because again, this is actually a volunteer opportunity for humans to be involved in clinical trials. I know we'll talk particularly about cancer clinical trials, but I just wanted to set the stage so that you'll be familiar with the term clinical trials, or another name, clinical studies.
Thank you, Dr. Allen. So Dr. Northfelt, I'm going to ask you a question and have you talk a little bit about some of the clinical trials that have made important advances in systemic therapy about breast cancer. But can you talk a little bit about the precautions that have been taken to protect patients who are participating in clinical trials?
Sure. First of all, I'm very grateful to be here with my esteemed colleagues to talk about this very important topic. I want to quickly give an example, which I think is very pertinent to the discussion here. And this actually has nothing to do with breast cancer, but it's a clinical trial that's very relevant for the African-American community. There was a study done recently where the focus was on children with sickle cell disease. And I'm sure that everybody who's listening is aware of the burden that sickle cell disease has in the African-American community, and some of you may have friends or family members who are affected by this problem. Some very, very clever, thoughtful scientists recognized that by changing the gene in the patient's cells that causes the sickle cell disease, by changing that gene, they could make the person well, change the nature of their bodies in a way that would eliminate the sickle cell disease. So this was a clinical trial involving gene therapy, where a gene was being given to a patient. It was determined that the best choice of individuals to participate in this opportunity would be children who would live to be severely affected by sickle cell disease if something wasn't done to help them. And so some very, very courageous parents and some very courageous children with sickle cell disease agreed to participate in a clinical trial, in a research study, just as Dr. Allen was describing. In that study, the children were given the new gene to replace the gene that was causing their sickle cell disease. And it worked. It cured those children of sickle cell disease. Now, as a result of that clinical trial, the courageous parents and children who agreed to participate, who had that opportunity and agreed to participate, this is a strategy, a treatment that's going to be made available to anyone who has sickle cell disease. Those who participated in the clinical trial proved that this was an effective way to manage sickle cell disease, to eliminate it, so that child could grow up and live a healthy life. So through the courage of the parents and the children who participated in that clinical trial, there is now an opportunity for anyone in the world with sickle cell disease to receive curative gene therapy for their problem. We're looking to do similar things in cancer. And here to speak about opportunities to do this in breast cancer, we have medications that we think are going to be useful to treat breast cancer. These are new drugs or new treatments identified by the scientists who can make a difference in the treatment of breast cancer. Before we know that these things can work, we'll have to look for people who are willing to participate in clinical trials to help us prove that those treatments are effective. Once that proof has been obtained, then the treatment can be made available to anyone who needs it. What Dr. Halyard was referring to a moment ago was the protections or the safety features that are involved in running these clinical trials. And this is an extremely important thing as we're offering these opportunities for people to obtain new treatments for cancer. We have to make sure that we're not going to harm them in the process. And so very careful screening of patients is undertaken, looking at everything about their health to make sure that it's going to be safe to give them this new drug or this new treatment. We also want to make sure that this is done in an ethical way, that we're not abusing people in the process or willfully harming people in the process, especially without informing them of that risk. And so very strong safeguards have been put in place for anybody who's considering enrolling in a clinical trial. Those safeguards are designed to make certain that people are not going to be harmed unknowingly. And we keep safety in the forefront in that way to protect people who are attempting to gain the opportunity that the clinical trial provides.
Dr. Northfelt, you pointed out risk, and I think one of the terms that is often used, and perhaps our audience will recall, is minimal risk, correct? So there's minimal risk when we're looking at clinical trials. As I mentioned earlier, whatever trial that is going on, it has been tested over and over and over again for a substantial number of years or time to determine if it is appropriate to provide or be given to human beings. And I wanted to ask a quick question when you talk about things that are put in place. What are some of those things that are put in place, like perhaps the review board?
Sure. So let me take you back to the beginning of this. A scientist comes up with a great idea that could change the way that cancer is treated and make the world better for everybody with that disease. That scientist will propose that idea to the Food and Drug Administration, to other regulatory bodies and government, will propose that strategy or that research project to review boards within their institution. At the Mayo Clinic, we call it the IRB, or the Institutional Review Board. At various levels, there is scrutiny placed on what the plan is, what is going to be done to people who are participating in this study. And at every level, it has to be clear to those participating in the review that this is reasonably safe and reasonably effective to allow it to be ethically performed in people. So, Dr. Allen, what you're referring to, I think, is the fact that there are multiple levels at which people scrutinize these plans to make sure that they're as safe and as appropriate as they can be before people are asked to volunteer to participate.
Absolutely. And I also want to include that the review board actually have community, people of community, people who are in the community, excuse me. So they have a say-so of what is going to be take place when we talk about clinical trials, not just people who are experts in the field, not just clinicians, but also people who are in the community that represent the community in which you are going to do clinical trials with.
That's absolutely true. You know, thank you for mentioning that, Dr. Allen, because we're looking for people to participate with us at Mayo in some of these processes of looking at clinical trials for their appropriateness and their safety for the community involved before we move forward with them. So anybody who's listening to this who has an interest in participating in this process, we'd love to see you and talk to you about it.
And I ask that question specifically because many times I think when trials may be offered to people within the Black community, the first thing that we think about is Tuskegee and the fact that therapy was withheld from Black men who are intentionally who have been infected with syphilis. And so that was a long time ago. And what we know about clinical trials today, and I've written trials, Dr. Northfelt has written trials, Dr. Allen has written trials, is that there are so many safeguards that did not exist that we have learned from the past about past mistakes. And so many safeguards have been put into a process that are so rigorous and detailed that it protects what we call human subjects, i.e. the patients that we are serving. And so what happened those many years ago can never happen today. In addition to everybody that participates in research, whether it's designing research studies or putting patients on trials, has to go through regular and repeated education about ethical clinical trials. How do you protect patients, abuses that have happened in the past, not only to people of color, but also others as well. And so I just wanted to really kind of bring this point out because I think it's a hindrance sometimes to us as people participating in trials. And the only way that we'll know if really trials work on everybody, not just the majority population, is to participate.
You know, there is a resource, I think, for people who belong to this organization to consider taking advantage of if they're thinking about participating in clinical trials. If you're part of the CBBC and you're thinking about participating in a clinical trial, you could bring that thought to this group and run it by your friends and run it by Dr. Halyard and Dr. Allen and say, what do you all think about this? Would this be something that I should participate in? One of the great things about this community that I know about the CBBC is that you've got one another. And if there's ever a question about whether a clinical trial, for example, would be right for you, bring it here. Run it by your friends and the people who run this organization, because you've got a tremendous resource to help you with that.
Oh, I just wanted to add to what Dr. Halyard stated regarding training. As she pointed out, as scientists, we do have to go through training, and we also have to update our training. So it's actually something that is required of us for every 5 years, we have to update training. But as a result of the Tuskegee study that many of us hear about and talk about in the community, the training has taken place. And actually one of the trainings talk about the Tuskegee study, and we learn from that. So it's not something that's new to us. It's not something that we're just brushing off and saying, yeah, we read it before. It's something that we have to read over and over again to understand why there's so much concern in the community of people of color and others being involved in clinical trials. So I think that's so important to know that.
Yeah, I think there's a lot of shame in the research community about abuses such as what occurred with the Tuskegee experiment. And I think, those of us in this era of clinical research all learn about that, all think about that, and all take that to heart and know that we don't want that ever to happen to anyone ever again.
And one of our participants in the chat said that she had a niece that died at a young age, as well as someone else that she knew that died of sickle cell. And we just think about the advances that have been made that will hopefully prevent those deaths in the future. Before we open up to questions, I just wanted us to talk a little bit about the advances that we've seen in our specialties that have come from the result of research. So I've been in oncology a long time, over 30 years, and I remember back in 1984 reading a paper in a prestigious journal that showed that unequivocally, for the majority of patients, mastectomy was equivalent to breast-conserving surgery. This was revolutionary. Prior to that, women routinely, like my mother, underwent radical mastectomies where not only the breast, but also the chest wall and the lymph nodes were removed. And I saw her from the time I was 5 to the time she died when I was in my 40s, her suffer the consequences of that mutilating type of surgery. She survived, sure, but did she need to? We learned from studies that extensive surgery could be modified to a modified radical mastectomy, where they left the chest wall muscles. But even that, for many patients, is not what many patients would do if given the choice. And back in 1984 was really the first time that we saw long-term follow-up of studies that had treated half the women in the study with mastectomy to half of the women in the study with breast-conserving surgery, otherwise known as a lumpectomy, with and without radiation, and saw that there was no difference in survival. And so mastectomy for most women with breast cancer, not all, but most women with breast cancer, has become a choice, or breast conservation has become a choice. Without that, we would never have, that research we would never have known. Think about how far we have come with lymph node sampling and lymph node dissection. We used to routinely take out, in my mother's era, just about all of the lymph nodes under the armpit. Patients got really big swollen arms or lymphedema. Now, today, patients will get what's called a sentinel lymph node sampling if we don't know that their nodes are actually involved, where we inject dye and a tracer into the tumor that drains to the first drainage group of nodes. And if those nodes, the few nodes that are taken out by the surgeon are negative, it saves the patient from having more extensive surgery. It saves that patient from chances of developing lymphedema. We would not have known that without research. As I think about in my own specialty, when I first started, and some people still do this, 5 to 6 weeks of radiotherapy or more was the standard every day for 5 to 6, sometimes almost 7 weeks of therapy. We learned from studies that have been done in this country and other countries that for many patients, 3 weeks, sometimes 4, was perfectly equivalent to 5 to 6 weeks by giving higher doses of radiotherapy per day, which allowed us to cut down on the number of treatments. And everybody in the field said, well, if you give higher doses per day, you're going to get more side effects. Guess what? Research told us that was not the case. It told us that the survival was the same, the control of the cancer was the same, the side effects were the same, and actually the amount of skin reaction was a bit less. Fast forward today, we have studies that have been done from the United Kingdom. We did a study at Mayo Clinic in Arizona that looked at, for appropriately selected patients, half patients getting 3 weeks of treatment, half the patients getting 5 days or 1 week of treatment. And lo and behold, we found the same thing as when we compared 6 weeks to 3 weeks. Equivalent survival, equivalent outcome, slightly less skin reaction. Without research, we would never have known that. And right now we have a trial going on asking that same question about 3 weeks versus 1 week in lymph node positive patients, because the other trials largely had lymph node negative patients. We hope to answer that question about the effectiveness and the safety. So it's just an example over my lifetime of 30 plus years of being in the oncology field, how the field has changed so very much. Dr. Northfelt, I bet you can think about changes in ER positive, triple negative, HER2, and also HER2 positive patients in your career.
Yeah, it's you just inspired me to think about the strategy of less treatment maybe being just as good or better. And something very similar to that has happened during my practice career. Back in the early 1990s, I'd see a woman who just completed surgery for her breast cancer. And every one of them, I recommended chemotherapy. Chemotherapy to reduce the chance of a relapse of the cancer. But we knew that many of those women probably would have been okay without chemotherapy. We just didn't know how to identify who are the ones who could avoid chemotherapy versus who are the ones who really should have it to benefit them. So then the scientists caught up with that, and in the last 10 years or so, clinical trials were done. Women enrolled in those studies. Those studies used a genetic test on cancer to determine whether chemotherapy was essential for that woman's well-being, or maybe chemotherapy was a why bother. And those studies were done, women participated, women volunteered for those studies. And eventually it was shown that there's a large group of women who are identified by this genetic test who don't need chemotherapy. They're going to be fine without it. So it completely transformed my practice from 30 years ago, I gave everybody chemotherapy. Now it's a minority of people for whom I recommend chemotherapy. That's all because women were willing to participate in clinical trials that proved that we could use that genetic test to avoid chemotherapy in a sizable number of people. Yeah, absolutely. We just need to be smarter, and we get smarter by having patients participate in clinical trials to show us the way. These women were brave. They were, taking a certain chance, but they could see that by doing so, they were going to make the world a better place for themselves and for other people. That's the real motivation for participating in clinical trials.
And Dr. Northfelt, what are some of the trials that might be open now either at Mayo or nationally that are some of the most important trials that you can think of?
Yeah, I like to highlight the trial that we're participating in at Mayo called I-SPY. And I apologize, I don't remember what the letters stand for, but really the idea behind this clinical trial is to identify situations where new drugs could be introduced into the treatment of women with advanced breast cancer, where those new drugs could provide great benefit for those women. And this is a nationwide study that's going on. It's been going on for the last 10 years. And they've cycled through a number of new treatments and proven a number of new treatments that are very valuable for women with advanced breast cancer. So that's one where I'm extremely grateful that we have the opportunity to offer that clinical trial opportunity to our patients at Mayo, because I know I'm getting them cutting edge treatment, the best that's available, the best that the scientists have identified, and we're seeing real progress in that.
So why don't we open it up to questions now? Anybody have any questions or comments? Denise?
Yes, I have a question. I actually am a participant in the trial, or was a participant. It was a 3-year trial, and my 3 years are up, although the trial group still sends certain information to me. So I don't know if you've talked about this, it wasn't a clinical trial related to treatment or anything like that. It was, I believe, a therapeutic trial. I don't know. So what are the other types of trials / studies? And I don't know if it's a difference between using the word trial and study, clinical, therapeutic, or whatever. Is there any more light to shed on the types of studies, trials we can get engaged in beyond?
Sure, maybe I could answer that because I know what clinical trial she was in. So Denise was in a clinical trial where she wasn't being given a drug or a specific treatment to see if it would change things for her. She was enrolled in a trial where education about lifestyle was the topic. So in the study that Denise was involved in, half of the women were just given some information to read about exercise and about nutrition as a way to improve their outcome with respect to their cancer. But the other half of the group got not just that printed information, but they were receiving phone calls periodically from a coach who would help them stay on track with their nutrition, stay on track with their physical activity as a way of enhancing their health. Now, the results of that study that Denise was involved in, those results have not been finalized or reported yet. But what we're hoping, what the scientists are hoping to show, is that the women who get the extra encouragement from the coach calling them periodically are going to stick to their nutrition and stick to their physical activity more effectively and get a better outcome as a result. So that's not a therapeutic trial. It's more of a non-therapeutic interventional trial to see whether a different strategy of living actually is going to improve the outcome of Denise's health.
Yeah, and I'd like to elaborate. I think that was an excellent question, Denise, because people often confuse the clinical study with the research studies and research that's out there. And many of you may be familiar with research studies, quantitative or qualitative, and it sounds like that was more of a qualitative when they did the asking questions and interviews, et cetera. And so oftentimes that is an opportunity for you to have a voice at the table or represent a particular group, particularly what they're looking for in that area. Again, remember when I introduced clinical trials, clinical studies, it was drugs, it could have been vaccinations, and other methods where a human subject is being involved in something to test something out. In this case, and in that case, it was more getting your opinion or getting some information from you. This is where you'll see surveys, questionnaires, or perhaps gather individual groups of people together to ask them questions to get their feedback. So there are differences between the research studies and also the clinical trials. So that's an excellent question.
Thank you for your answers.
So one of our participants that recently completed treatment at Mayo, are there any clinical trials that one can participate in? I think we don't see that last part of the chat, but I think you're saying after you've participated in a clinical trial. Do you want to unmute and ask your question?
Thank you, Dr. Halyard. Yes,
Yes.
that's my question. Are there any current trials out there that I can participate in if I have completed treatment of my breast cancer?
So I will answer that question. So without knowing or without revealing a lot of details specifically, that is the approach that I think anybody should take in that situation is asking your oncologist, are there any trials that I should participate in or could participate in either at the institution where you're getting your treatment or elsewhere. everybody, there are different trials that are going on in different institutions. So not uncommonly, cancer centers can't participate in every clinical trial that's out there because of limitations of resources to open trials. And so particularly for patients, for example, in the metastatic setting, there may be trials that are open at one institution that are not available at your institution, or even non-metastatic settings. So ask that question. Ask the question, and you can contact myself or Dr. Northfelt related to any trials. From the radiation therapy standpoint, not, but there may be something from that.
If I could just comment very quickly too, Lisa, I don't remember if we enrolled you in the clinical trial that I'm about to describe, but if we haven't, I think we could. There's a clinical trial going on right now at Mayo where your genetic testing is done on a very broad scale, and that's to determine if you have any genetic predisposition to cancer. This is information that could be quite important to you because if we knew, for example, that you were predisposed to colon cancer, we would want to do more for you in terms of screening and trying to protect you. So I can't recall if we enrolled you in that study, but if we haven't, we can. And I'll try to check your schedule and make sure that I'm talking to you about that next time you're at the clinic for a visit.
And I may add this, Lisa, depending on how the protocol is written, some providers may not ask you. The protocol could be written where there's a flyer in the lobby, or there are certain things that are listed on the internet or Facebook. Because again, depending on how the protocol is written, whatever recruitment strategies are put in place will determine how you are being recruited.
But I would ask, because there are some cities that are not actually therapeutic, as Dr. Northfelt said. So there may be questions, or protocols that are dealing with symptom control, right? I'm having hot flashes. Do you have any trials for hot flashes? I'm, have gained weight during chemotherapy. Are there any trials related to X, Y, or Z? So it doesn't only have to be active drug or radiation or anything else of that nature. And there was something in the chat about the person that asked, said that she has a niece with sickle cell. So that is actually, I don't know if that's in standard clinical practice or if there's still trials, but we don't have a big sickle cell practice at Mayo, but there are other centers around the country that are. So I would actually go online and look at sickle cell treatment centers and try to ascertain that way how to get the information. And actually, there have been on some of the news shows actual stories about patients who have benefited from this therapy. Very inspiring young Black women who were just crippled by their disease with painful sickle crises. These individuals, if you're not familiar with sickle cell, wind up going into the emergency room in pain crises and excruciating pain, often undertreated because people think it's drug-seeking behavior, unfortunately. And this is just revolutionized their life as a result of the trials and the growing people that said, yes, I am going to contribute and hopefully help myself, but also help science.
So Jeanette, if you can maybe message Denise at some point and tell her where your niece lives, I can do a little search and find out where in California that study might be going on, or it may be possible shortly to get that treatment without participating in a clinical trial, because I think the FDA is getting close to approving it. But send Denise to your niece's city, just so I know where in California she is, and then I can look into where that kind of approach might be available.
And before I ask another question, there's one thing that I want to clarify. We talk about scientists designing clinical trials, but these are not necessarily people that are sitting in a laboratory with no access to patients. Some mad scientist who's been copying, I think I could try this on a patient. I mean, some of the trials I've written in my life have been cancer symptom control trials. So when I treated head and neck cancer, I did a trial on acupuncture for dry mouth. I've done trials for other it's not necessarily what you think. And those scientists that are sitting in the laboratory with an IQ of about 300 are really important people because they partner with us as clinicians to look from their perspective of the science, our perspective of the science, and collaborate to design studies for the betterment of patients.
Yes, of course, I'm filled with questions. In preparation for the meeting, of course, and I saw a few studies at Mayo Clinic, one in particular that I'm curious about. I don't mean to put you on the spot if you don't know, but it has to do with the cardiologist. Thank you, Michele, for helping me that. Do you know what's going on in that realm?
Yeah, so that's a study for women who have HER2 overexpressing breast cancer. They're going to be receiving the drug called Herceptin, which is the medication used to treat that particular type of cancer. So the cardiologists at Mayo are intensely interested in that drug because we know that a small number of people develop heart failure when they receive that drug. It's about 4 or 5% of people who receive Herceptin or trastuzumab who develop heart failure. So the cardiologists, as I said, are intensely interested in trying to figure out how to prevent the heart failure associated with that treatment. So they've got a study going at Mayo that we're enrolling patients in now. So if a woman is about to start treatment with Herceptin or trastuzumab, she can be enrolled in that study. And the way I look at it is that I'm giving that Herceptin to the patient, but there's a cardiologist looking over my shoulder the whole time, making sure that we're keeping that person safe. And there's a strategy built into the study to try to protect the heart. So that's what that's about. It's a heart protection strategy that they're studying with this up.
Would you know if there has been any studies around the heart and triple negative breast cancer?
I'm not aware of specific studies where the intention has been to understand heart problems developing out of treatment for triple negative breast cancer. We do know that the drugs that are used to treat triple negative breast cancer can at times injure the heart, and also that radiation can at times injure the heart. So research that's been done in the past has enlightened us about that and given us some strategies that we can use to help people who develop that problem. Also, the radiation oncologists are really on top of that with their research, looking at ways to spare exposure to the heart from radiation that could be damaging. I don't know if you want to say.
Yeah, there have been studies, and sometimes the scientists or scientists or just clinicians who are in research look back at experiences, and that's a type of research that we can do even without enrolling patients. And so, for example, within our field, we look back to say, what's the threshold of radiation dose to the heart that gets people into trouble long term? The heart damage generally manifests itself a decade or more after radiation, 10, 15 years. But what are the doses? And there's some classic papers that show the more dose you give, the higher the risk, but it's kind of it's not, the lower doses are probably safe. And so from that, it allowed us to do studies that looked at different ways to treat patients. Sometimes we treat them on their stomach if they've got a left-sided breast cancer, and allows us to avoid the heart. Sometimes we, through the knowledge gained in studies, done deep inspiration breath hold, where we time the radiation beam with patients taking a deep breath, which pushes the heart out of the way. And all of these things have allowed us to improve our practice, improve what we do for patients, and decrease side effects. So again, the theme here hopefully is coming through that we are today where we are because of what we've learned from studying questions that arise in treating patients, and we need patients to participate, particularly patients of color, in these trials to make sure that everything that we think that we're doing, that we think are applying broadly, actually do apply to everybody broadly. And what our advances in the future are going to be dependent on everybody helping us answer the most pressing questions. I think one of the greatest trials that I've been a part of at Mayo was it's called N9831, and that was one of the foundational studies that showed that trastuzumab or Herceptin cut the death rate in HER2-positive breast cancer by 50%. In that, before that drug was introduced and studied, women had a terrible survival and had HER2-positive breast cancer, and it was transformative. So, you know, it's Dr. Northfelt and I he's got obvious gray hair, my gray hair is hidden. Dr. Allen doesn't have it, he's young. But we've all been in the field long enough to see how studying the questions, trying to continually improve the care that we provide to patients is being translated into saving lives.
I do want to add, one of the things, and thank you, Dr. Halyard, for pointing out people of color. And Dr. Northfelt, you pointed out that you had a couple of studies. What is your greatest challenge, or have you noticed any greatest challenge of people of color when it comes to research, particularly clinical trials, I should say?
Yeah, you know, I think I had to change my language around the importance of clinical trials to really get the point across in a way that made my patients feel comfortable, all my patients, but especially the patients of color. And what I realized a few years ago was that what I was talking about was opportunity. I was talking about opportunity to take advantage of new cutting-edge strategies, new drugs, new treatment schemes that were going to make a difference, a positive difference for people. And I realized that my job was to explain to all people, especially skeptical people, especially worried, nervous people, maybe worried and nervous for historical reasons, to explain to them that this was really about opportunity to get something better. And that in the past, I think people of color were denied those opportunities. And it sort of became a mission, as I was thinking about it, for me to make sure that those opportunities aren't being missed anymore by my patients of color.
But I think that's an important part of this discussion is that there may be trials out there in the institutions that you're going to, and hopefully not in ours, but you know, sometimes people might not think of a trial that is open, that you may not be given the opportunity to participate in. So it's incumbent upon you, even if you have no intention of participating in the trial, even if after they explain it to you, like, nah, don't want to do that. But you need to know what's out there, and you need to know, are you a candidate for a trial that perhaps may give you a greater opportunity to cure your cancer or avoid side effects or things of that nature. So please ask. We talked a lot about the first hour having that confidence, that voice from coming to CBBC. So for all of you who are out there listening, ask that question. And it doesn't have to be just for cancer. If you are treated for diabetes or hypertension or any other things that we have that go wrong with our bodies, ask the question, is there a study that's available? And even some private practice groups do clinical trials too, so you do not have to be treated in an academic medical center always to avail yourself of a clinical trial or research.
And I want to add that I noticed Dr. Halyard said if you were going through, there are also clinical trials, clinical studies, and research studies that look at preventive measures. Also, if you have a family history of, so there may be opportunities for some of our listeners if you have unfortunate situations where you have breast cancer or some type of cancer, but you're looking at the generation behind you, your children, your grandchildren, or your siblings. You want to try to see what can we do to help prevent these things. There may be opportunities for them, and of course, we're looking at with clinical trials age 18 and above, as otherwise noted. But there are other opportunities, and we encourage you. I brought that question up to you, Dr. Northfelt, because the people I work with in the community, they often will bring up the Tuskegee situation, and I have to enlighten them and share with them the detail. The Halyard study has also been a hot topic, and I think one of the greatest concerns, and I'm surprised, is I don't want anyone to draw my blood. I'm afraid of needles, or I'm afraid that they're going to give you something. Have you ever run into anything like that?
Well, I have to say, in my practice, the issue about drawing blood doesn't come up so often because we are so routine sending people to the lab for blood testing for various reasons. If I'm just giving regular chemotherapy and having to keep somebody safe, that involves testing their blood periodically to make sure that I'm not leading them down the road with something dangerous. So I'm grateful that I haven't had that particular barrier come up. But I want to answer your question another way because I'm staring at Lisa's name on the screen here, and I love her so much because she's a dynamic, impressive woman. I proposed to her at a point a couple of years ago that she participate in a clinical trial, and she declined, which is her right. You know, I said, "Would you like to do this?" She said no, and we moved on. And then later she came to me and said, "You know, I would have participated in that clinical trial, but you just didn't give me enough time to really think it through, and I was feeling pressured because I had a new diagnosis, and felt like I needed to move on with my treatment." Well, God bless you, Lisa, because you taught me something so critical in that moment, which was I need to slow down and take a little time when I'm explaining about one of these opportunities to somebody to really give them the ability to understand what I'm talking about and really put it in their own context so they can recognize when it's going to be good for them. Because I know that Lisa, when she came back, she said, "You know, I would have done that, except you didn't give me enough time to think it through." So that was a huge learning moment for me, and I'm so blessed, Lisa, that you provided that to me.
I think what's more important, Dr. Northfelt and Lisa, is that you have a relationship. For her to be able to come back to say that to you, that speaks volumes. And I think not only just having the time, but having that type of relationship with your provider so that they can communicate.
And I would say that take the time that you need to make the decision, right? The consent form doesn't have to be signed that day. You need to read the consent form, make sure you understand it, have somebody just explain it to you again if it doesn't make sense. Take the time that you need, just like you need to take the time that you need for any treatments that you might be undergoing or any other thing that you might participate in. So if there are any other questions in the last minute or two, if you're on Zoom, please unmute yourself because we can't see everybody. We're not on gallery. If you're on Facebook Live, please send information to our questions to cbbcaz.org. Is that good? Info@CBBC.
Info@CBBC. Yeah. .org.
And we'll answer those questions. We're not seeing the Facebook Live questions at this point. So anything else? If not, we thank you for joining us today. We hope that this gave you good information. As always, we post our information on our CBBC site usually within the week. If others could benefit from this information, please let them know, and we look forward to seeing you next month, even on Father's Day. All right. Denise, any final remarks?
Well, we may have something special on Father's Day, so we'll get plenty of information out there to you early.
All right. Good. Thanks so much, everybody.
Bye.
Bye.